The topic of this lecture is renal system disorders with a specific focus on acute kidney injury and chronic kidney disease. What we'll look at during our time together is the common etiologies and pathologies of acute kidney injury. We'll describe how the pathophysiology of diabetes, hypertension, and polycystic kidney disease can actually lead to chronic kidney disease. We'll look at the impact of decreased kidney function on phosphorus and calcium metabolism and homeostasis, and then also talk about some additional multisystem effects of chronic kidney disease. We'll start with acute kidney injury. Acute kidney injury, I've provided the diagnostic criteria for acute kidney injury. And these were published by the KDIGO, the Kidney Disease Improving Global Outcomes Group, as our clinical practice guidelines for acute kidney injury in 2012. Again, it's not so much, I don't want you to memorize these diagnostic criteria. What I do want you to do is focus on the concepts. And the two important concepts that you can see here is that when we diagnose acute kidney injury, we're using functional parameters. We're using an increase in the serum creatinine, either a specific increase within 48 hours or an increase from baseline within about 5 to 7, usually 7 days. The second one, and the one that we can depend on a little bit easier, is the urine output. And it's critical that you understand that pathophysiologically in an adult, the minimum urine output is 0.5 mLs per kilo per hour. And if an individual has that for a minimum of 6 hours, they meet the criteria of acute kidney injury. Now we know that in a child or in a neonate, that minimum urine output is based on the age as well as the weight of the child. But this is what it is. This is how we diagnose for an adult and an older child. When we think about the etiologies of acute kidney injury, they generally fall into 3 major categories, and these are pathophysiologic categories. And lots of different individuals' pathologies may lead us there, but the overall concepts and mechanisms are important to remember. And etiologies include pre-renal, post-renal, and intrarenal pathophysiologies. So when we look at a pre-renal acute kidney injury, what we're looking at over and over, and the key here is a decrease in the effective circulating volume that is reaching the kidneys. Now this concept of the decreased effective circulating volume is pathophysiologically important because this may be due to volume, this may be due to changes in hemodynamics, or it may be due to resistance. So let's think first about volume, because that's the one that really makes so much sense. So when you think about someone who is dehydrated, who has a hypovolemia, it makes sense then that as far as the kidneys are concerned, and in reality, they aren't getting enough circulating volume, not enough effective volume, because there isn't enough volume in the vascular space. And of course, that's going to stimulate the renin, angiotensin, aldosterone system in order to try to compensate for that pathology. Hemodynamics also is very important. When we think about hemodynamics, we need to think about whether or not heart function is adequate in order to circulate the kidneys. So let's think about someone with reduced ejection fraction heart failure. When the heart is putting out a decreased ejection fraction, when there is less blood coming out of the heart, once again, what do the kidneys get? Not enough. They have a decrease in effective circulating volume because the heart isn't working. At the same time, think about someone who has sepsis. When someone has sepsis, they have a very low systemic vascular resistance. Because of that very low systemic vascular resistance and a lot of vasodilation, how much blood are the kidneys getting? You're right, not as much. So again, it's the effective circulating volume that is reaching the kidneys that matters. The kidneys don't mean to be single-minded. However, they are very sensitive and they know whether or not they are getting enough blood volume, and they respond appropriately. The last is resistance. It's important that we remember that there has to be a positive net filtration pressure in that glomerulus. The oncotic pressure within the capillary bed of the glomerulus has to be able to overcome the opposing pressure in Bowman's space, so that if there is too much resistance in Bowman's space, there will be a decrease in the effective circulating volume. If there is a decrease oncotic pressure, a low serum albumin or low serum protein level, you've lost that oncotic pressure, once again decreasing the effective circulating volume to the kidneys. What's important to remember about pre-renal acute kidney injury is the pathology is not in the kidneys. If you circulate those kidneys, they're more than happy to do their job. That is the same thing that's true in a post-renal acute kidney injury. The kidneys are not damaged. However, they are being affected by backward pressure. So when we think about a post-renal acute kidney injury, there is some sort of an obstruction either inside or outside the system that is causing backward pressure, and there is that net filtration pressure. The pressure in Bowman's space is higher than the filtration pressure on the arterial side. So without that net positive filtration pressure, they cannot filter. So if we think about backward pressure inside the system, think about someone, a male who has a very large prostate gland. That would cause urine to back up into the bladder. The urine then will overcome the one-way valve at the end of the ureters and backflow through the ureters into the kidneys. Now, in order for someone to have a post-renal acute kidney injury, then whatever this obstruction is, it has to be bilateral. So if I had a big old kidney stone sitting in my left ureter, my right kidney is going to filter a higher solute load, and I would not undergo acute kidney injury. However, if I only had a solitary functioning kidney and that one had a big old kidney stone in it that was stopping the flow of urine and causing backward pressure, I could experience acute kidney injury. So those are some examples of what could happen inside the system. Well, what about outside the system? Think about large abdominal masses, like a large ovarian tumors, colon cancers, where there's so much tumor mass that the tumor is actually pressing on those ureters and causing constriction of the ureters, and the urine that is being that ultrafiltrate and that urine that is being made by the kidneys simply can't exit the kidneys themselves, causing backward pressure. Another potential is the pregnant uterus. During late in the third trimester, some women will develop a hydronephrosis. It can be unilateral or bilateral and cause an acute kidney injury. The third general etiology or pathophysiology is intrarenal. When you have an intrarenal acute kidney injury, now the pathology is in the kidneys. The kidneys themselves have been affected. So restoring circulation or taking pressure off isn't the problem. The problem is inside those kidneys themselves. And this is where we talk once again about basement membrane versus tubular epithelial membrane damage. As long as the basement membrane remains intact, the probability of recovery is greater than if the basement membrane is affected and severely damaged. Now, an intrarenal process may be from a glomerular pathology, or it can be from tubular interstitial pathology. But remember, the key here is the pathologies in the kidneys, as opposed to pre-renal and post-renal, which where the kidneys were okay, and if you either circulated them in pre-renal or you relieved the pressure in a post-renal, the kidneys can respond and recover. Let's think then about how these mechanisms actually play out. Well, something has to get it started. Low volume, an MI that causes a reduced ejection fraction, prostatic hypertrophy that has caused hydronephrosis, or a nephrotoxin causing an intrarenal damage, but something gets it started. From that initiating factor then, this will lead to both renal as well as cortical ischemia within the kidneys. That ischemic process will lead to a glomerular vasoconstriction. That glomerular vasoconstriction will cause a decrease in the glomerular filtration rate and the amount that glomerulus is able to filter. When you decrease the GFR, you automatically decrease flow through the tubules. If you decrease tubular flow, what's in the lumen of that tubule, that will lead to oliguria, because remember, oliguria is the amount of urine that's being put out. Well, urine comes from the tubules. Remember, once the urine leaves the collecting ducts, it is what it is. What's also very interesting about this pathologic mechanism is there are phases of this pathology. You have an initiating phase, and when you know that, and when you start seeing an AKI, or that you know you have someone who is at high risk, you keep your eyes open so that if they do start to have difficulty, turn them around, get them some volume, take the pressure off. That's the initiating. If we are unable to relieve the initiating factor, or if the initiating factor continues, generally this will then lead to an oliguric phase. In this oliguric phase, there is a decrease in the amount of urine being produced by the kidneys. And what would that be? Less than 0.5 cc's per kilo per hour. So that would be an oliguric phase. So that's when you know that the kidneys are certainly struggling. Now, the first sign of recovery is the diuretic phase. So this is actually a sign of beginning recovery of the kidneys. What's key to remember the pathophysiology of this diuretic phase is that initially the individual will put out urine of a fixed specific gravity. So they're putting out fluid, but the tubules have not had the opportunity or been able yet to recover that reabsorption secretion function. And so that's why the specific gravity is fixed. They're not able to fine-tune, for lack of a better phrase, that urine. The diuretic phase is important because they may put out a fair amount of water. And when they put out a fair amount of water in their urine, you have to be sure that they don't become pre-renal. In the recovery phase, this is when the kidneys actually start to heal themselves and recover from the pathology. Recovery can take anywhere from several weeks to several months. What we're seeing is individuals who used to die while they had acute kidney injury are now surviving whatever caused the acute kidney injury, and they're actually surviving longer, and although they may need ongoing kidney replacement therapy. The last key concept of pathophysiology of AKI then that I want to leave you with is, before we go to the next step, is that this is virtually always a complication. It's a complication of something else. AKI is almost always a complication of another pathology that has negatively affected the kidneys. Now, we also know that as an intratubular process, kidneys can undergo acute tubular necrosis. There are three major categories or etiologies, pathologies of ATN. It can be ischemic, it can be nephrotoxin related, or it may be post-organ transplant as a result of the immune response. We already talked about post-organ transplant as a cell-mediated immune response involving T cell activity, so I'm not going to cover that one. Let's take a look at ischemic injury, however. So this is someone who has ischemic kidneys, and first thing, remember that kidneys already pretty much work in a relatively hypoxic environment. So they actually do pretty well with a fairly low oxygen environment. But what happens with this ischemia is the microvasculature becomes vasoconstricted. As a result, then, they're unable to respond to those endothelial counter-vasodilating biologic mediators. So you have microvasculature vasoconstriction. Remember, the glomerulus is a knot of capillaries. You have in this ischemic injury, that response to the biologic mediators for vasodilation are disrupted. This then leads to vascular smooth muscle injury as well as coagulation and inflammatory mediators. So ischemia leads to inflammation. Because of the decreased ongoing vasoconstriction and the inflammatory process, the cells continue to be hypoxic and they have fewer nutrients being delivered because of the decrease in circulation. As a result, the cells become have an increased rate of apoptosis as well as necrosis itself. Then what happens, because remember this is acute tubular necrosis, you will have tubular obstruction of the cells that begin to slough off and die from the endothelium, and the tubules become obstructed. As the tubular lumen becomes obstructed with all of the cellular debris, remember there's going to be leaking into the interstitium, which further complicates the pressure on the tubule. Another important pathology in AKI that can cause injury to the tubules are nephrotoxins. There are a variety of ways that nephrotoxins can cause AKI. One is through direct cellular destruction, and these can direct cellular destruction can either be by endogenous or exogenous materials. The two most common endogenous materials, the one from our bodies, include hemoglobin and myoglobin. Hemoglobin we are especially concerned with if you have a blood transfusion reaction with hemolysis. That free hemoglobin is directly toxic to the cells. With myoglobin, a crush injury and muscle cells are being broken down very rapidly. Myoglobin is also released into the circulation. The kidneys aren't able to reabsorb myoglobin appropriately, and there is so much of it that myoglobin is a direct cellular toxin for the kidneys as well. So those are endogenous direct cellular injuries. You can also see direct cellular destruction, direct cellular injury from chemicals as well as heavy metals. Now, the other thing with nephrotoxin pathology are drug-induced nephrotoxicities. Drug-induced nephrotoxicities can come from a variety of mechanisms, and this can be from a hemodynamic mechanism, it can be from a glomerular permeability increase, or from tubular damage. When we look at hemodynamic drug-induced nephrotoxicity causing an acute kidney injury, we're looking primarily, or in many cases, we're looking at medicines that change the hemodynamics within the kidneys. That's what angiotensin-converting enzyme inhibitors and angiotensin receptor blockers can do. You can actually become nephrotoxic from both of those medicines. Nonsteroidal anti-inflammatories also change the hemodynamics. Remember those prostaglandins? Prostaglandins are vasodilators in the kidneys. What do NSAIDs do? Block prostaglandins. So as a result then, nonsteroidal anti-inflammatory effects can change the hemodynamics within the nephron, within the tubules, and cause a nephrotoxicity. Now we can also have a pure glomerular dysfunction. This isn't as common as the others, but what happens with a glomerular-induced nephrotoxicity is that there is increased permeability of the glomerular capillary bed, or that basement membrane. This is what you can see with lithium toxicity, with a heroin toxicity that affects the kidneys, and also is yet another pathway that nonsteroidal anti-inflammatory drugs can cause damage to the kidneys. The third drug induced is a tubular nephrotoxicity. This is what happens with many of the antibiotics, especially aminoglycosides. This can also occur, once again, yes, you guessed it, with nonsteroidal anti-inflammatory drugs, as well as iodine-based contrast. They become directly toxic to the tubular cells. The last and most common pathology of nephrotoxins and how they can affect or lead to the overall pathology of an acute kidney injury is interstitial nephritis. Now again, this is primarily due to nephrotoxic drugs, and this is the most common form of a nephrotoxin-related pathology, is an drug-induced nephrotoxicity is an interstitial nephritis. What happens in an interstitial nephritis is the drug is a hapten, and that drug, it's called a hapten because it usually would not be considered an antigen, but it becomes antigenic, and the drug actually binds to tubular cells and becomes antigenic. Now what's interesting about this is, in general, any drug can cause an interstitial nephritis. Some are more likely to cause an interstitial nephritis than others, but virtually every drug has the potential to do this. So how then does an interstitial nephritis manifest? A usual interstitial nephritis is an allergy-like response. Remember what we talked about. The drug binds to the tubule, and it is essentially an antigen. So it doesn't surprise us then that the interstitial nephritis would be an allergy-like response. So what would you see in the plasma? What kind of cells would you see in the plasma as well as in the urine? Yes, eosinophils, that allergy-like response. You would also see some common hypersensitivity or allergy-like responses. Rash, may have some itching. Most nephrotoxic interstitial nephritis occurs within 30 days of being placed on a medicine. So that's one of the other things to watch for if someone presents in this manner. Now, NSAIDs are tricky. You understand why I think NSAIDs are evil. So with a nonsteroidal anti-inflammatory interstitial nephritis, you don't see the allergy-like symptoms. So you don't see the eosinophils, or if you see them, they're very low, not very dramatic. What you do see is more protein in the urine, hyperkalemia, and volume alterations with an NSAID-associated interstitial nephritis. The other thing that's tricky about an NSAID interstitial nephritis is it may not manifest as quickly. It has an extremely variable time frame, and someone could be on an NSAID for a year and never develop an interstitial nephritis, or after having tolerated it for that long, now they develop an interstitial nephritis. So it's an extremely variable time frame. The population to be especially aware of with the interstitial nephritis are elders. They tend to have more hyperkalemia, more protein in their urine, and more hypertension because of the volume from an NSAID nephrotoxic interstitial nephritis. So let's turn our attention from acute kidney injury to chronic kidney disease. Once again, I've provided the diagnostic criteria from the KDIGO group. Notice that what we're looking for is kidney damage for greater or equal to 3 months. So this has to have been occurring over time. Also, what's very important is what we look at is a glomerular filtration rate less than 60 milliliters per minute for that 3 months with or without kidney damage. And what we look at is our GFR as well as albumin in the urine. So that's the concept I really want you to have a handle on, is that when we look at chronic kidney disease, we're looking at something that has been present for a minimum of 3 months, and we are looking both at the glomerular filtration as well as or the presence of albumin in the urine. So those are the two key concepts that we want to remember. So let's put this then in diagnostic criteria. With chronic kidney disease, we look at disease grades. And as you look at grade 1, you can see that there's kidney damage, but they have a preserved glomerular filtration rate. What's a normal glomerular filtration rate? Well, it's definitely greater than 90, absolutely. It's about 110 to 125, because remember, it's a reflection of the creatinine clearance, or the creatinine clearance is a reflection of the glomerular filtration rate, actually. With grade 2, you see that the glomerular filtration rate has dropped below 90, but it's right around 60. Grade 3 is a huge category and a very active pathophysiologic category. That's why they separated it in 2013 into 2 grades, 3A and 3B. What is very significant about grade 3 is this is when we begin to see the systemic manifestations of chronic kidney disease. This is when you may start seeing mineral bone metabolism disorders with calcium and phosphorus derangements. This is where you start seeing the anemia of chronic illness because of a decrease in the amount of erythropoietin being produced. With grade 4, the GFR has dropped below 30. Now, in grade 4, this is a significant grade of kidney disorder because when we think about nephrotoxins, many of our drugs are pretty safe until that glomerular filtration rate drops below 30, and that's when we need to start thinking about renal dosing medications. So it's very important that you remember that when you take your pharmacology course. And then in grade 5, we are looking at a GFR that is less than 15, and this is milligrams percent per meter squared. It is absolutely inappropriate to describe kidney disease or a stage of kidney disease as renal insufficiency. So I know you still hear that in practice, but it means nothing because it isn't descriptive. When we use these grades in describing kidney disease, it really helps us understand exactly where their glomerular filtration rate is and the systemic effects of that. The second piece that's important in diagnosing chronic kidney disease is whether or not there is albumin in the urine and how much albumin is there. So we're looking at the albumin to creatinine ratio. Remember, less than 30 is considered within normal limits. Between 30 and 300, we know that that is altered. And between 30 and 300, we know that there is alteration. And greater than 300 is significant. So then when we classify CKD, we look at the cause of the CKD. Was it glomerulonephritis? Was it ongoing acute kidney injury from a nephrotoxin? Is it from diabetes? Is it from lupus? And etc. We look at their glomerular glomerular filtration rate category, or their grade, and we look for their albumin category as well. Once again, I do not expect you, and neither do I want you at this point in your careers, to memorize these grades and categories. I want you to understand the concept, and that as albumin, as you get over 300 milligrams of albumin, and that albumin to creatinine ratio, that's significant. When the GFR drops below 60, that's significant. And when the GFR is below 60 is when you start seeing the systemic manifestations of diseases and how they affect the kidneys, the rest of the body. Let's start by talking about diabetes-associated nephropathy, or diabetic nephropathy. We're starting to change terminology a little bit from diabetic nephropathy to diabetes-associated nephropathy. I left diabetic nephropathy on your slide because that's the way McHance and Huther describes it. Diabetic-associated or diabetic nephropathy is the leading cause of end-stage kidney disease worldwide. Now, diabetic nephropathy has both an inflammatory as well as a non-inflammatory glomerular pathology, but the pathology is in the glomerulus. The inflammatory pathology is a result of an elevated blood sugar being pro-inflammatory, as well as the inflammatory effects of glycated end products of glucose metabolism. The non-inflammatory pathology is due to the vessel damage that occurs with accelerated atherosclerosis, as well as changes to the vessel from the diabetes or the metabolic syndrome. We know that because this is glomerular, that the afferent and the efferent arterioles are very important in diabetic nephropathy. The vascular pathology that we think about is due to the increased pressure within the glomerulus that damages that basement membrane, that basement glomerular membrane. That microvascular damage with the glomerular changes occurs initially as manifested by a hyperperfusion and a hyperfiltration. However, as this hyperperfusion and hyperfiltration continue, the microvascular damage and glomerular changes continue to occur, and damage to the basement membrane occurs. The second part of this pathology are changes in the mesangium as well as the basement membrane. The mesangium, which is the supporting structure, becomes thicker and thicker. Now, in type 1 diabetes-related diabetic nephropathy, the mesangium is less affected than it is in type 2. As we affect that mesangium, we begin to lose our podocytes. Our basement membrane is being damaged. So let's look at the differences between type 1 and type 2 diabetes. The hallmark sign of diabetic nephropathy in both type 1 and type 2 is the beginning of, it begins as a small amount of albumin, usually about 30 milligrams. And this then begins to progress to proteinuria and the nephrotic syndrome. Remember that albumin to creatinine ratio would be greater than 30. We know that the glomerular damage, this proteinuria, is increased with an A1C greater than 7% and further complicated if there is hypertension. In type 1 diabetic nephropathy, this affects about 40% of the individuals with type 1 diabetes, and the onset is usually 10 to 20 years after the diagnosis of type 1. In type 2 diabetic nephropathy, this affects about 40 to 60% of patients, and diabetic nephropathy is frequently present at the time of their diagnosis. So we always double check albuminuria when someone is diagnosed with type 2 diabetes, because remember, a lot of this has been silent up to this point. When we talk about diabetes, we'll talk about the differences in the pathology of type 1, type 2. Type 1 doesn't go on for years without being recognized, but type 2 does. Now, what's really interesting is if someone has had diabetes, either type 1 or type 2, and they have not manifested diabetic nephropathy after they've had diabetes for about 25 years, they probably aren't going to manifest it. They've escaped it. Now, one of the things we looked at that was very important was the long-term benefits of intensive glucose control in preventing end-stage kidney disease, and that makes sense. If the risk increases with an A1C greater than 70%, then it makes sense that we should want to control that glucose carefully and therefore prevent diabetic nephropathy. And what we found in the Advance-On study is that in a study that followed about 8,500 patients, a mean of just about 5.5 years, we were able to prevent type 2 diabetes. However, the effects were greater in early stage CKD and with a lower baseline systolic blood pressure than if they had later stages CKD. So what I'm really telling you is we had to control that glucose early on. We couldn't wait until they already had manifested with albuminuria. However, despite the positive effects, there was no difference in risk of death, cardiovascular death, or major cardiovascular events by level of kidney function, even though we controlled their blood glucoses. A second important pathology is hypertensive nephropathy. This is, again, a non-inflammatory glomerular pathology of a vascular etiology. With hypertensive nephropathy, this carries two different pieces of pathology. One is atherosclerosis, and we talked about hypertension and atherosclerosis being a major pathology that leads to hypertension. So you can imagine then that atherosclerosis is happening in the very small vessels of the glomerulus, as well as glomerular pressure, because as you get more and more vascular changes, that will then lead to sclerosis of the vascular bed, therefore increased pressure. The hallmark sign of hypertensive nephropathy is proteinuria with CAS. Now that's different from diabetes, isn't it? The hallmark with diabetic nephropathy was proteinuria, and you may not see a lot of CAS in a diabetic nephropathy until it's quite advanced. Now, the proteinuria, while it is significant, frequently is not quite, doesn't usually get into the 5, 6, or 7 gram range that you would see with a true nephrotic syndrome. Signs and symptoms of hypertensive nephropathy vary with the severity of hypertension. And we know that the kidney effects of hypertension, just like hypertension, are generally silent. But it is the second leading cause of end-stage kidney disease, and or high blood pressure results from the end-stage kidney disease due to volume overload that frequently goes with advanced and those advanced grades, late grade 4 and grade 5 of kidney disease. So diabetes-related nephropathy is the leading pathology that causes end-stage kidney disease worldwide. Hypertensive nephropathy is the second leading cause in the U.S., but it also in other countries as well has a significant impact. In individuals of color, individuals of African American descent, especially males, hypertensive nephropathy has a tendency to progress more rapidly in that population than in Caucasians and to a lesser extent in Hispanics. And why this progresses more rapidly in African American males probably has some link in the genetic makeup. So we want to remember about hypertensive nephropathy is it is characterized by vessel damage, remembering that the glomerulus is a capillary bed. The third disorder that I wanted to talk about is polycystic kidney disease. Polycystic kidney disease is the most common genetic disease that leads to kidney failure, to end-stage kidney disease. Polycystic kidney disease is an autosomal dominant genetic defect. That is the most common. There is also an autosomal recessive, but is much, much, much less common than autosomal dominant. So what you're likely to see is the dominant form. The two what the defects we're looking for is PKD1 and PKD2. These are polycystins. PKD2 is polycystin, which is a protein. Both PKD1 and PKD2 help transport calcium into cells. In addition, PKD2 polycystin regulates the growth and differentiation of the tubular epithelium. So that then makes sense why this is a tubular epithelial disease characterized by multiple cyst formation. Autosomal dominant polycystic kidney disease is a disease that usually is found during the 3rd to 5th decade of life. So although the child is born with the autosomal dominant disorder, it does not manifest until later in life, usually during middle adulthood. What happens as a result of changes in the PKD1 and PKD2 is multiple cysts form within the kidneys. And these cysts continue to expand. Remember that polycystin regulated the growth and differentiation of that tubular epithelium. So as those cysts form and expand, they begin to stretch and narrow the intrarenal vessels. Because of this narrowing and stretching, this leads to ischemia, which then stimulates the renin-angiotensin-aldosterone system. This is what causes the major manifestation of the disorder, which is hypertension. The second manifestation that many folks will identify is back pain. Because if you think about these cysts and they're getting bigger and bigger and bigger and bigger, well, remember that the kidneys are covered by a tough fibrous capsule. So these cysts are actually stretching and stretching and stretching that capsule, and so they, as a result, they present with back pain. Now, these cysts can become obstructive as well as hemorrhage. However, when they hemorrhage into the parenchyma. They don't burst that capsule, so you don't have that capsule bursting. What you would have is hematuria. The larger the kidneys become, the greater the pathology, the more extensive the pathology, and the greater the likelihood that this will lead to end-stage kidney disease. So this is one of those questions that you would ask on as you're doing a family history to determine whether or not there is any history of kidney disease, or if anyone died of kidney disease, when they found out they had it, and what the kidney disease was a result of. The last two things we'll talk about are two additional effects of end-stage kidney disease, of chronic kidney disease. And these are mineral bone metabolism, and then we'll summarize with some effects on cardiovascular disease. With mineral bone metabolism, once again, we're back to the hormone-related functions of the kidneys. The kidneys are responsible for the synthesis of 1,25-dehydroxycalciferol. D-hydroxycalciferol is necessary for vitamin D metabolism. Now, alterations of synthesis of D-hydroxycalciferol actually begins in grade 2. However, it becomes especially prominent in grade 4. In the absence and the role of 1,25-dihydroxycalciferol is to activate vitamin D, and the active form of vitamin D is D3. So without that hormone, we're unable to activate vitamin D3. As a result, then, calcium is not absorbed efficiently from the GI tract, and the body has a way of handling that. Calcium is going to be removed from the bones. In the meantime, however, the kidneys are unable to reabsorb calcium, and the plasma level of calcium begins to decrease, and the phosphorus level is increasing. This then stimulates the parathyroid glands to release parathyroid hormone, and the idea there is to increase the serum calcium level. However, remember, the kidneys aren't working. We have to have that activation of vitamin D12. I'm sorry, vitamin D3, vitamin D. So what you have then is a relative decrease in the serum calcium and a significant increase in the phosphorus levels, because calcium and phosphorus have to balance themselves. The end result of this poor calcification and increased phosphorus is an alteration in mineral bone metabolism, that phosphorus and calcium metabolism, which has both negative bone as well as cardiovascular effects. What happens in the bone is that there is altered bone turnover, and they call this adynamic, or a loss of the dynamic turnover of bone tissue. So what happens then is, with this mineral bone metabolism, either there's not enough parathyroid hormone, or the bone becomes resistant to parathyroid hormone. And this can happen in this adynamic bone disease. This is one of the major complications of having chronic kidney disease. The lack of erythropoietin causes a significant anemia, and the altered bone mineral metabolism with increased levels of phosphorus, which causes a decrease in calcium, causes significant potential bone disease. Now, we also have difficulty with cardiovascular disease in end-stage kidney disease. Individuals with end-stage kidney disease die of the same thing that the general population does. They die of cardiovascular disease. They don't die of their kidney disease. They die of cardiovascular disease. People with end-stage kidney disease have an increased incidence of MI as well as stroke. Chronic kidney disease is a risk factor for the development of cardiovascular disease. What we see in individuals with chronic kidney disease is dyslipidemia and hypertriglyceridemia. So not only do they have lipid alterations, the LDL, elevated LDL, total cholesterol, and a decrease in HDL, which, remember, was our scavenger, they have a very high level of triglycerides. And this is something that is a little different in the chronic kidney disease population, is you will usually see a bigger impact of triglycerides than you may the pure lipid disorders. We've talked about anemia. As someone becomes increasingly anemic, they may have hypoxic chest pain, because they're anemic, they can't carry enough oxygen, and therefore they have ischemic related chest pain due to the anemia. Individuals with chronic kidney disease tend to have low serum protein and serum albumin levels. We know that the risk of death and the increased risk of adverse drug reactions is greater in this population because as the serum albumin level drops, they are more likely to have adverse drug reactions because of protein binding of many drugs, as well as they tend to have an increased risk of death because of poor nutrition. We've talked about hyperparathyroidism. Because of the increase in phosphorus and the decrease in calcium, parathyroid hormone continues to be produced, and that then leads to bone mineral metabolism, which can further lead to calcification of the arterial media and the valves. So when you think about cardiovascular disease in these patients, you have calcification of the arterial media, which is significant, as well as hypertriglyceridemia, which increases atherosclerosis. Individuals with end-stage kidney disease are also likely to experience volume overload. As a result, they are more likely to develop heart failure. Initially, that heart failure may have a preserved ejection fraction component, but as the heart continues to get bigger and bigger and more stressed, will lead to a reduced ejection fraction heart failure. And then last but not least, uremia itself is pro-inflammatory and continues to feed the inflammatory process, which further complicates atherosclerosis, the mineral bone metabolism issues, anemia, and the difficulty with nutrition and further decreasing albumin levels. So we've talked about, once again, a lot of different things. So what should you have a good understanding of? Certainly have an understanding of the concepts behind the 3 different types of pathologies that can lead to acute kidney injury. Can you think them through? What about chronic kidney disease and the importance of the grade of the glomerular filtration rate? As that glomerular filtration rate drops below 60, systemic manifestations become greater and greater, and the effect on other body systems then becomes greater, both in terms of anemia as well as mineral bone metabolism especially, but then also nutrition and inflammation. We talked about diabetes-related nephropathy, the hallmark of that being albumin in the urine, and that can progress to a nephrotic syndrome. We know that whether they're type 1 or type 2, there is a similar pathology, but we also know that it will manifest a little bit differently in terms of when we recognize it, simply because we catch diabetes nephropathy in a type 1 earlier than we do in type 2. We looked at the vascular effects of hypertension and how it also leads to chronic kidney disease and damages the kidneys as a vascular pathology. But we looked at that pathology as being proteinuria. We will see some nephrotic range, but not generally does not go as high as it does in diabetes, and we always look for casts in a hypertensive nephropathy. And then we also looked at the primary genetic disease in chronic kidney disease, polycystic kidney disease, and I would have an understanding of how that is transmitted and the pathology of how polycystin leads to the formation of cysts. Then we ended by talking about the negative effects of chronic kidney disease on bone mineral metabolism, which all starts with the lack of the hormone dehydroxycalciferol coming from the kidneys as they fail. And then we also look at the numerous effects of chronic kidney disease as it manifests in the cardiovascular system, not only in terms of hypertension and lipid disorders and hypertriglyceridemia, but how anemia can affect cardiovascular function, how mineral bone metabolism can lead to additional cardiovascular disease, how volume overload is going to affect the heart, and the pro-inflammatory of uremia. As always, I absolutely appreciate your attention, and if you have any questions, please let me know, and Thank you for letting me talk about kidneys.